Today's episode of Beyond the Mask is presented by the insurance specialists at Bright Think Wealth Strategies. Find the disability insurance coverage that fits you best right now. Email Robert Smith at rsmithjr@financialguide.com. The show is also made possible by the team at CRNA Financial Planning. Get a free consultation today to be guided through the complexities of investing and financial planning. Just visit crnafinancialplanning.com. We'd also like to thank Helping Hands and OSA EMR for their support of the show. And don't forget, listening to our podcast can earn you Class B credits. For more information on how you can submit them, check out the CE Credit tab on our website, beyondthemaskpodcast.com. Welcome to Beyond the Mask, Innovation and Opportunities for CRNAs, with Jeremy Stanley and Sharon Pierce. We know you spend your day caring for your patient's best interests. On our show, we want to care for you. Join us as we leave the operating room and learn the latest in the CRNA industry. Beyond the Mask starts in 10, 9, 8, 7.
Today we're going to finish off our conversation on Manpower. This is part 2 of the discussion, so if you haven't had the chance to listen to part 1, go back and check that one out as well. Now, here's the rest of our conversation.
So what do we know about Manpower from 2010 to present? Boy, we've covered a lot of years.
We have, yes.
You're looking good, Jeremy, for all the years
thank you.
Well, how about us, Sharon? We have really covered a lot of years.
Covered it so more.
100 years together. 100 years together. We've walked this path. Walked through snow, climbed the mountain.
Barefoot, uphill one way.
Centurions. Isn't that what it is?
Well, one of the things that we know is that there has not been a comprehensive AA&A Manpower study published in the last 13 years.
And I don't know, that's a bad thing. You know, they're very expensive to do.
Yes, they are.
How much would you estimate, Sharon?
Gosh. Well, just a minimal study is $250,000.
Oh, yeah.
Yeah.
Easily.
I had no clue.
Until we did that one, that podcast with Lorraine. I knew that, and even though I took a lot of heat for that $1 million from MBCRNA, it has funded 6 studies. And they're not done yet, some of them.
Yeah.
So in 2019, there were 121 educational programs in the United States, as compared to in 2000, there were 93 programs. In 2006, the number was 106, and again in 2019, it was 121 educational programs. All programs were offered a master's degree after 1998. The first doctoral program listed in 2008, and in 2019, there were 92 doctoral programs, 29 master's programs, still at the master's level. But by 2025, all graduates will have a doctoral degree at entry into practice.
I wonder how many of those are going to close. We were looking at those numbers. COA was reporting to us. So what I'm hearing is in 2019, there were still 29 who had not transitioned.
I'm guessing that it won't be a lot. I think some of them were just waiting till the last, like Wake Forest, for example. Some of these programs started an optional doctorate, but are still graduating at the master's level for the entry, into anesthesia. So I feel that probably all of them are university-based, and I don't think we'll get many closures. I'm guessing not. But we'll have to wait and see.
Yeah. And so in 2021, the total number of CRNAs was 56,027. The total number of student nurse anesthetists at any point in the educational program in 2021 was 8,092. And graduates per year, approximately 2,697 during this time.
So I'm going to go back to what I said earlier when we were talking about this was, or if there are 56,000 and half of them retire, that's 28,000, right?
Okay.
And over the next 10 years, so that means in 10 years, if we just keep our graduates constant, there'll be 28,000 retiring and 26,970 put in the workforce. again,
we're just keeping up.
Which can leave the door open for, as Sandy mentioned, other people to kind of step in here if the supply continues to go down and the demand continues to go up like we think it's going to. So something to be cognizant of moving forward.
And, when Nancy mentioned in 2021 there were 8,092 students in any part of their program. Remember, during that time, some are still 2 years and some are 3. Some have already transitioned to the doctoral for entry, and some are still at the master's, and will be transitioning this year because all programs have to have a doctoral degree this year. Because it's a 3-year program,
right?
To graduate by 2025 at entry level doctoral prepared CRNAs.
So potentially in 2024 we could see a dip in graduates because instead of putting out in 2024, they'll graduate in 2025.
Yeah, I thought that, but maybe not as much as we thought, because so many of the programs have already
staggered them.
They've staggered it,
yeah.
and
they were hoping that didn't happen.
Yeah,
That's why
and I don't think it'll have the impact it could have had.
Right, if we wouldn't have been cognizant of that fact.
Exactly.
Yeah. So, since we have not had any of our studies, and it's good anyway to look outside ourselves, I went and tried to see what I could find out from other groups about what they're thinking in terms of manpower for both nurse anesthetists and anesthesiologists. One was a Radius Anesthesia reported in March 2018, where they said 48.3% of all anesthesia providers are anesthesiologists, while 49.6% are CRNAs. The anesthesia work faces regional variations, a growing concern about shortages, a greater influx of women into the workforce, and increasing utilization of non-physician providers. Influential factors for recent workforce changes include an aging population, as Nancy mentioned, and cost containment efforts in healthcare, and changes in structure to the healthcare system. So I thought that was pretty interesting. And these non-physician providers, it probably was referring to anesthesia assistants as well as nurse anesthetists, anything that's not an anesthesiologist. All right, so there was a Merritt Hawkins white paper. Are you familiar with them, Jeremy?
Yes.
I was not. And I thought it was a very good paper, and it was 2019. It was CRNA supply, demand, and recruiting trends. And for our people listening that do not know about Merritt Hawkins, it is the nation's leading physician and advanced practitioner search and consulting firm. And they produce annually a series of surveys, white papers. They do speaking engagements and other resources intended to provide insight into healthcare staffing and recruiting trends. And I think this may be somebody good to have at an annual Congress. I just found them, so I don't know what the negatives might be, but I found this paper very interesting. What they said were, the CRNAs are the primary provider of anesthesia care in rural America, and we've always known that. In some states, CRNAs are the sole providers, and nearly 100% of rural hospitals are the sole provider of anesthesia in 2/3 of rural hospitals nationally. CRNAs administer more than 49 million anesthetics each year, according to an AANA 2019 member profile survey. And I'd like to pause at this time and really request our members pay attention to, when you get your dues statement, there's always a survey. Please fill out that survey. It's completely anonymous. When only 10% answer the survey questions, you have to question, are we getting the broad view of the answers to the questions we're asking? And this member survey is used to help us advocate for the profession, and it doesn't take long to complete this survey, so please do it. Merritt Hawkins also said that CRNAs are unusual and that practice of anesthesia is recognized as both a nursing and medical specialty unified by the same standard of care. And, I like that statement coming from that particular group. So we've got 1 foot in medicine and 1 foot in nursing, which I've always said, but we're unified by the same standard of care. And 40% of CRNAs are men, compared to 10% of nurses generally being men. According to the U.S. Bureau of Labor Statistics, job growth for CRNAs is projected to be 26% between 2018 and 2028, a 10-year period. Job growth, 26%, which is well above the national average. And the reason for this increased demand is a largely driven by an aging population. And the utilization of specialty services driven upward by years of economic growth following the 2007-2008 recession, giving patients the option of undergoing more elective procedures, and I'm still thinking about my facelift that I might have.
There you go.
Yeah.
I'll put you to sleep.
Yeah, I got that.
Just wake her up.
Yeah, that's right. And a lot of things we could get done. And another would be proliferation of sites where procedures can be done as a factor. Doctors' offices, physicians' offices, GI centers, and just all sorts of places. And the lack of anesthesia providers in rural America opens the market for CRNA jobs there. And this group went on to say the continued effort of healthcare facilities to cope with rising costs and the declining reimbursement for these healthcare facilities also stimulates demand for CRNAs. And you mentioned that, Jeremy, when our salary approaches that of the anesthesiologist, we're not going to be near as attractive as we are now. And I don't think anybody can really fuss about their salary right now.
No.
It's pretty nice, pretty sweet.
It's pretty good. Yeah.
And then the outcome data for CRNAs are positive, indicating a positive fit for emerging quality, value-based reimbursement models. There's not been, and we've done this before in terms of quality outcome studies, there's never been one that shows a difference in outcome based upon provider. So, and it's so good that people outside ourselves are picking up all this stuff.
Absolutely.
And they're doing the pom-poms, and they're doing it for us, and that's good. A clear indicator of the rise in demand for CRN services is a listing of both anesthesiologists and CRNAs in a list of 20 most requested search assignments. Anesthesiologists and CRNAs had not been included in the top 20 since 2009. And so he went on to say to everybody that's thinking about having to recruit CRNAs, and I find this interesting, we know that there's a shift in priorities in the workforce. As we've gone from one generation to the other. We've moved further and further away from the Depression to many generations now living the good life for a good while. So they want different things. And I like what he pointed out. CRNAs have many options to choose from today. He pointed that out. So if you're trying to recruit a CRNA, it's made more difficult because they have many 1099 opportunities to choose from. And so that's really good for our people that really want to retire but really keep a hand in, that they can do that and work several days a month or a couple days a week or whatever.
Yeah, and then, with opt-out and less barriers and, even with COVID, COVID helped that situation out a little bit as well. So.
And then he went on to say, if you want to really be at the top of the walk in terms of recruiting, you've got to offer clinical autonomy. Allow CRNAs to practice independently to the highest level of licensure and limit physician oversight to a minimum required. Practice autonomy may be the single most important factor CRNAs consider when evaluating practice opportunities. And avoid physician-only cases, such as only the doctors can do this nerve block, only the doctors can do these epidurals. The future for recruiting CRNAs, if that's going to be your workforce, is not there for hospitals that continue to do that. And to offer flexibility in the work schedule. 60% of potential recruits are women who require a family-friendly schedule. And then be competitive. CRNAs rarely relocate for an average salary. They may, if the spouse has moved or whatever.
But
if they're really looking, for other reasons, they want to be upgraded.
As a CRNA, you spend years preparing yourself for this career, so we don't want to see you lose out on any of the income you've worked so hard to earn. The best way to protect yourself and give you the confidence that a major life event won't disrupt your financial future is through disability insurance. We've known disability income specialist Robert Smith for many years and have seen the work he's done with nearly 2,000 CRNAs over multiple decades. He can help identify any gaps in your existing coverage and fill those gaps by finding the best value on a policy. Contact Robert and let him know you heard about him on our podcast. Send him an email at rsmithjr@financialguide.com. That's rsmithjr@financialguide.com. Or call him at 504-394-6557. Protect your greatest asset as a CRNA, yourself and your ability to earn a living by adding disability insurance to your financial plan.
Well, in that same study that I was talking about in the AANA journal, good heavens, I wish I had it right here in front of me, but it's talking about why did CRNAs leave, and the take-home was for hospitals not to think that it's based on poor leadership within the anesthesia department, that CRNAs leave a department for other reasons. It's usually not related to the leadership. I'm
going to have to look that article
It's
up.
really good.
It's probably the end of 2021, probably December journal maybe.
I think Dan Lovenaria is on the cover.
Okay.
That one.
Okay.
With his dog?
No, he's intubating somebody, and it's not a dog.
What's that dog's name? Hermes?
Hermes.
Hermes?
Hermes.
Dan, I'm sorry for calling your dog the wrong name. I apologize again.
Dog's going to pee on you next time it sees you.
Oh, goodness. And this stuff is so interesting to me because it just goes right up my alley. And I mean, and I do hear CRNAs that, money is a big factor, obviously benefits, but autonomy, like I said, the lady we were talking about earlier, she doesn't want to go to a place that she can't do the types of things that she's done in the setting she's in now. And if you limit that for CRNAs who are laid back, type B personalities, never want to mix it up, you are cutting your nose off to spite your face in the CRNA marketplace. So great point, Sandy. Good find on that, too. Yeah, I'd seen that Merritt Hawkins stuff several times.
I thought it was
They've
excellent.
done some really good
There was nothing biased about it.
No.
It really it presented all of our educational background and everything, and it was spot on.
And I think mainly they do physician recruiting. So they do some CRNA, but I think mainly they're physician. Coming from them, this is big.
Yes.
Yeah. So, well, goodness, we have touched on a lot of stuff in these episodes.
Yes, we have.
Yeah. So, all right. So let's get some closing thoughts going on here as we wrap this one up.
Okay. So, as I was doing, a search on the computer, I found an interesting article written by an anesthesiologist from California, and he had worked both in the academic center as well as private practice anesthesiology. So he talked about 10 trends he sees for the future in anesthesiology. Some I agree with, some I would say I got to see it to believe it, but we'll see. The one that I paid great attention to, lower income as adjusted. Everybody wants to hear that, don't we? As we move into the future, we're going to get a lower income. As adjusted for inflation due to an aging population and more payment coming from the federal Medicare system. I can see that.
Yes.
Government payment cuts, bundled payments to hospitals with a fight for fair share of payment. If we get it bundled, one person is going to take care of that money for that whole procedure. Hopefully it'll be the hospital. That'll be favorable to us, but it'll be less. And then incorporate anesthesia. Well, I can see that, Jerry. What do you think?
I could absolutely see that.
Yeah.
Absolutely. I think he's always dead on because, adjusted for inflation, we have been in this really low inflation environment for a long time, and now we're starting to see that unravel. And once you get 7.5–8% inflation in the economy, it takes a long time to get this out, to retch this out.
And I don't think it's going to get any better. Well, I think it's going to get worse, inflation, in the next 2 or 3 years.
We'll see. I think some of that was COVID and the supply chain disruptions. I think, personal opinion, I think the worst of the inflation is behind us. But you cannot get back out wage inflation. You can't get back out rent inflation or housing inflation. Sharon, if I give you a raise at your job and just because inflation goes down, I can't go back and take that away.
Right.
It's already in there. And that's what happens with inflation. It builds upon itself. And that's what the Fed wants to do now, is slow down the...
Okay, that took me a second.
Yeah.
Yeah.
So, and that's what the Fed's trying to do now, is
It's
they're going to raise rates.
Programs. You can't institute
take it away.
them, and then you can't take them away.
You know, so, and then the fact that we do have this massive amount of money that the federal government injected into the system, that money's still out there. I mean, they still haven't started retching that out of the economy, which is why, you know, the cost of goods and services have gotten bid up. And this is a really complicated thing, but I'm going to digress on that because I could talk about that forever. But, you know, Sandy, I think he is dead on here. We know that we're moving closer and closer to that one-payer system. We're moving closer and closer to all payments being bundled. And then you've mentioned this before. You both have, actually. You know, who's going to be in control of that bundled payment? If it's the anesthesiologist, CRNAs are in trouble. That is a key moving forward. Yeah,
so are hospitals.
Well, yeah, you're right.
Yes.
You're right.
I can't
Absolutely.
see it being any other way except the hospital, the facility.
Yes.
Yes.
You know, being in charge. So,
and then we know people are getting older, you know, and do
Yeah.
you need less maintenance or more maintenance as you get older?
Yeah.
I mean, there's the demand portion of it.
So anyway, the other thing he said, Jeremy, and I'm sure you have some ideas on this too. There will be more ACT anesthesia or more anesthesia care team models, which requires more CRNAs. Now, you have to look where he's coming from. He's coming from California.
Right.
And there you find more anesthesiologists, which we aren't used to in the South, west of the Mississippi, that will sit down and run a room and do their own cases, and they're okay with that. But he's saying it's going to go the other way, to the west. Facilities have increased incentives to provide anesthesia with cheaper labor. This will encourage the ACT model or CRNAs working alone. What do you think?
I think you're going to get more of the latter. CRNAs working alone. I mean, you know, ultimately this is going to come down to dollars. And, you know, I've said this as I've learned throughout the years, and, you know, we've seen our government at work, especially when healthcare is over 20% of GDP. We've got to drive the price of that down. And, you know, even though we spend more on it, it's not the greatest quality healthcare in the world either. So what's going to happen, in my opinion, is you're going to start to see more and more pressure to cut costs, which means the anesthesiologist is out of the equation. Now, what does that look like? I don't know. That's the multi-million-dollar question. But CRNAs can practice, do their thing autonomously. It's going to drive the price down, which is why I said earlier, let's be careful what we wish for. The higher CRNA salaries go up, the more this does not work. And then I think in the long run, the care team model, obviously, I mean, you all know, I mean, that does have a place in a lot of places. It does. I mean, but if you've got an ASA 1, 2, or 3, do you really need that anesthesiologist in the room unless something just goes bonkers? Probably not.
Yeah, you may see more shift from the direction model, which is the ACT model,
right.
To supervision model, as
Right.
Nancy has talked about before,
Right.
where you would have fewer anesthesiologists, and in some places none at all. So, you know, that's a real possibility. The other thing he mentioned is more new drugs that will change the practice of anesthesia. Now, the only new thing, well, there's been several new IV drugs, I think. Remazicon is out now.
Dexmedetomidine.
Yeah, that's a little bit older, but Sugamadex, it was approved in this country in 2015, I think. I can't hardly see. I say every decade we're at our peak. How can it get any better? And then they come out with something better. So he may be right, but this is one I've got to see type things.
Well, usually those new drugs, the cost is way up.
That's
right. They're wanting to limit Sugamadex, where I'm working a couple days a week because it's so costly. And boy, you know, I'd never used it until I went there. We don't have it in the office. I've always used neostigmine, and boy, what a difference. It's so hard to go back now.
Yeah, when Dick first heard Mark Welvier, he came here, the late Mark Welvier, he's a great guy.
Oh,
And he talked about it, and so Dick was still working then. And he went back to his hospital, and he couldn't wait to use it. But he missed one of the key points that Mark said. This is a reversal you don't use until you're ready for them to be reversed.
Absolutely.
Like 3 minutes. So Dick was giving it like you do when they're stigmate and Robenal, and he gave it, like 10, 15, 12 minutes. The patient was helping finish the case.
That's it, man. Giving you the finger.
I said, did you hear Mark say that?
That's like turning off the Remy fentanyl.
Yes, it is.
And then the aging population he mentioned, and we've talked about that. He says, this is interesting, anesthesiology will become more and more a shift work job.
I believe that.
You think so?
Yes. We're seeing that. People just don't want to take these long calls anymore. And, I mean, the literature's been coming out for a while about the exhaustion factor. And people are just, I absolutely agree with this.
And they say a long call is, 12 to 24 hours. Our long calls was 48 hours.
Oh,
we had the whole
Lord.
weekend.
Yeah.
We were Saturday and Sunday. When I became interested in anesthesia, one of the things that interested me as a student nurse is I saw the anesthetist leaving at 9 o'clock in the morning. They'd be having breakfast, at 9 o'clock in the morning. And I thought, I don't know what they do, but that looks pretty good to me.
You didn't know they'd been there all night?
They'd been there all weekend. They'd been there for 48 hours.
Oh, gosh.
Wow.
And he went on to say there will be increased interest in anesthesiology as a specialty, encouraged by higher reimbursement for a procedural anesthetist. And what he's saying here is, because it's almost contradictory to what he said
That's
above.
what I thought.
But he's saying, it may not be as good, but it's still better than the rest.
Yeah.
He's saying it's better than the internist. It's better than the pediatrician.
Yes.
They got to see so many patients every 15 minutes. You got one patient.
Piecework.
Yeah, that type of thing.
Yeah.
And expect improved safety statistics regarding anesthesia. I guess we can improve, but it's pretty good now with what we have. And number 8, he said there will be near zero incidence of anesthesia-related fatalities. There'll always be that airway problem. But I don't know how that could ever be eliminated if Untitled CO2 didn't do it and pulse oximetry. We're going to find ourselves in those situations from time to time, but it should be very rare. And large national corporations will continue buying up private practices. What do you think of that, Jeremy?
I mean, it's been the trend for a while now. I think we're still continuing to see it, especially in this environment, in a low interest rate environment. I think that'll change a little bit as rates go up. I mean, you've got large corporations who are sitting on a lot of money, and there's no other place they can put their money, so they're buying up these other ones and getting better multiples. And that's the bottom line in business is how can I get bigger multiples and make more money over time. But I think that'll change a little bit as rates ease up in the economy here, and kind of we start to see from this really low interest rate environment to higher. But I think the trend is definitely there.
And then the last one he said is there will be continued fascination with anesthesia practice, a discipline which makes all surgical treatments and cures possible. It doesn't happen without us, does it?
Yeah, anesthesia still absolutely fascinates me. 30 years, and it still gives me a lot of the same thrill it did 30 years ago.
It's like catching that blue marlin, Sharon. No matter how many of those captains have caught, when they hook a blue marlin, it's just like, that's the first time. It's the most excitement you'll ever see in the world. And, speaking of that last point, point number 10, that was what Ted Eager, the late Ted Eager, entitled the book, The Wondrous Story of Anesthesia. And it is. And, so if everybody's getting a reduction, you might as well be doing something you like.
Yeah. Exactly.
Today's show is brought to you by the folks at CRNA Financial Planning, an independent consulting firm that offers financial planning services exclusively to CRNAs and their families. From planning for a child's future college expenses to building a predictable income stream in retirement, The firm is committed to offering you comprehensive financial services, customized to fit your unique needs and objectives. If you have questions about your financial future, get them answered. Call the team at 855-304-3748. That's 855-304-3748. Or go online to crnafinancialplanning.com.
You guys have got a century of experience between you. Where do you see this all going? I want to hear your thoughts, not what's on the paper.
What do you think, Nancy?
I think that we will see more CRNAs doing anesthesia, and I think there will be, and I see less physicians entering this specialty because I think that, number one, there's no reason not to. Number two, the money is going to become a major issue. Mm-hmm. Hospitals are going to be pushed harder and harder and harder to contain their cost. I think you may even begin to see more hospital-employed CRNAs the way it used to be.
Or physician-employed, too.
And physician-employed.
Shift work.
By hospitals. And that's what I really think is going to happen. I think that in some ways we will go back to the way that it used to be, but it will be going back there with a lot more technology, a lot more knowledge, a lot of different ways to handle anesthesia, which will make it safer. And that's just how I feel it's going to be. I don't see any other way that it can go, because you may even begin to see just a total decrease in the number of physicians and an increase in nurse practitioners, an increase in midwives, because of the financial crunches that I see are going to be put on healthcare. It can't continue in this explosive way that it's been all these years, because we've got everything going against it. And one of the big things is healthcare has helped us live longer, live with a lot of comorbidities for a longer period of time. And you're going to have, I don't see the elderly population decreasing, I see it increasing, and they're not going to have the money to pay for the health care.
Right.
Yeah,
we can't spend our way out of this one.
Yeah, I agree with everything you say. And, as a consumer of health care, I can tell you most doctor visits I go, and particularly follow-up visits and things like that, it's a nurse practitioner or a physician assistant. And I've not had one that I was not pleased with. Yeah. And, you don't need a physician with all their years' experience to do a whole lot of what needs to be done. And that's good. And Jeremy, and I know that the federal government has been trying for years to get their hands around this health care dollar. Mm-hmm. And they're never going to give up until it's a single payer system, like you said, or a bundled payment system. And so everything that the future brings, I think is going to be driven by where the government goes.
Yeah. Well, I think what we've seen with healthcare is the government's let it get out of control, and they've let a lot of greed and money get into the system. And anytime you put, federal money and tax money into the system, people are going to figure out a way to reach up there and grab it. And we're seeing the same thing in the student loan sector. I mean, they let, the government wanted to give everyone student loans, and now you're seeing the cost of health care has gone up dramatically. More and more kids are getting out with more debt. You've got this huge student loan problem because the government put so much money in it, and now professors make more money, and we got new buildings on campus, and we've got this and that, and more technology, and cost, and they've let it get out of control. And both of those things are going to have to reach in and say, all right, the gravy train's got to stop. Who's going to be the ones that get cut out of that? Well, depends on who's got the best lobbyist, I guess.
There you have it.
But, to go back to one thing Sandy said, since I moved, I've been assigned an internal medicine physician. I've never met him.
Huh. Wow.
I'm serious. I've never met him. Don't know what he looks like. The physician assistant is the one that I see, and quite frankly, I don't care if I never see the physician. I like her, and she's personable. She finds out a lot about me that doesn't have anything to do with my physical health. I mean, she makes me feel like she wants me as her patient.
Yeah, you're not a number.
No,
Yeah, my doctor is an anomaly. I go in literally, and he talks to me for an hour. He said, "You're probably going to be the healthiest patient I see all day." But he wants to know everything that I've got going on in my life, my personal life. He asked me about the markets and stocks.
That's what he wants to know. That's the hour.
Is that what it is? Okay.
And it's free.
Where you paying him.
I'm paying him, yeah.
Instead of him paying you.
I was wondering why it went from a level 1 to a level 3 cost this time. Now I understand.
Yeah.
But no, I mean, he's definitely an anomaly. He's a great guy too. But anyway, but yes, I agree. Sharon, you got anything?
Listen, I think I'm with the wisest people on this, just listening.
I don't know if we're all the wisest, but we all have opinions about it, don't we? Well, Sandy, Nancy, thank you as always.
It's been
you
great.
Guys do a wonderful job, and I was just sitting here watching you two and listening to you two, and I remember the first time you came in and did this, and I have never seen Sandy nervous at anything, but she was nervous doing this, and now you both are like, I mean, you are pros at this.
Gosh,
I mean, you have got the knack now. I
we
love
were
it.
in Asheville.
Yeah.
That's
Right.
the first one.
Because I said I wasn't going to do it.
Yeah, you said you
I'm
weren't
not
gonna
doing
do it.
this. No.
And you didn't know what it was, and I almost was reduced to begging. But the funniest part is when we only had one microphone at that time, and they had to share it. And then Nancy kept raising her hand whenever she wanted to. I was like, Nancy, you don't have to raise your hand. And then I'm fighting over the microphone, kind of like. I guess it was kind of like that biology class.
Yeah, that's right.
Well, I want to say how much this is of value, I think, to the profession, both at the state level and the national level. I mean, I hear from people that have listened to, like, for example, when we talked about Catherine Lawrence, I couldn't find anything. And then Randy Cornelius, who's interested in doing the history of the Army CRNAs, got in touch with him immediately. He listens to every one of these, and he said, there's a whole book out on Catherine Lawrence. And so Nancy ordered it, and we got it, so we're going through that now. Yesterday, I got a very nice letter from one of our state representatives who Dick and I had donated to for the campaign. And without mentioning names, she had written a personal note that she really thanks the CRNAs for their support. But more important than that, she says, I love the podcast. So here's a state representative that listens to every one of these.
Yeah.
So that is really, really good.
Yeah, it is.
Well, just so you know, Sandy said she was never going to be speak in public, too.
I did.
Yeah, well, I've learned a long time ago, every time I say never. That's the next thing. You know, that's why I've got a tattoo. I mean,
That's what my grandmother always told me. She said, never say you're not going to do something because you will end up doing it.
Right.
And when I look back,
that's exactly right.
That's exactly right.
You put it out there in the universe,
laughs,
and God says, you know what? Let me show you.
I know one of the doctors I work with, who I adore, and whenever I got the tattoo, and he said, "You're going to have a sleeve one day." I said, "Not going to happen." He goes, "Yeah, whenever you finally do get grandchildren, they're going to go, Grandma," which they better not call me that. Grandma, why is my name not on you?
Right. Right.
Yes.
Believe me, they will call you what they want.
Oh,
That's
my
right.
Lord.
They will.
I know, and I'm a little scared.
All right. Well, this has been great. Again, we want to thank our listeners for listening to Beyond the Mask with Jeremy Stanley and
Sharon Pierce.
If you like our show and want to help it grow, Sharon, how can they help us grow?
Well, the number one way is to leave us a review, but make it
positive. There's definitely enough negativity in this world.
Absolutely. Share it on social media, which I've been doing on my personal page and getting a lot of uptake. So share it on social media and tell all your friends. I'm surprised. We did an interview this morning of a very prominent CRNA, and he didn't even know we did this.
Yeah.
You're kidding.
No.
It's surprising, and he's very
active
Yeah.
and didn't even know. So tell everybody. I mean, the hospital I work at now, they didn't know. And then whenever I told them they could get Class B credits, oh my goodness.
They're like, oh, great. Yes.
Yeah.
So, all right. Until next time.
It's a wrap.
Have you thought about what would happen if you weren't able to work for 2 or 3 years? You know, on average, 25% of people will file a disability claim, and most of us aren't prepared for that loss of income. Every CRNA needs to protect their biggest asset, yourself, and your ability to earn with a disability insurance policy. We recommend contacting Robert Smith, a master disability insurance specialist with more than 30 years of experience and 1,800 CRNA clients, to find the coverage that fits you best. The best way to do that is to send him an email at rsmithjr@financialguide.com. That's rsmithjr@financialguide.com, or call him at 504-394-6557. Beyond the Mask is made possible by the team at CRNA Financial Planning. With almost 2 decades of experience, the firm guides CRNAs through the complexities of investing and financial planning. Schedule a free consultation today by calling 855-304-3748 or go online to crnafinancialplanning.com.
Hi, this is Jackie Rolls, President of the International Federation of Nurse Anesthetists and President and founder of Our Hearts, Your Hands, a global anesthesia support community that takes donations to allow nurse anesthetists in low and middle income countries to go to educational programs, buy equipment, or textbooks. Your donations are tax deductible, and we would appreciate your support.
OSA EMR is a free anesthesia EMR developed by CRNAs that you can download and use on an iPad. Our nonprofit mission is to make sure that solo and small practice CRNAs can digitally record their anesthetics. To learn more, visit osaemr.com to download and consider donating to our cause. Remember, for CRNAs, data is destiny.
Be sure to subscribe to the show on Apple Podcasts, Google Podcasts, Spotify, Stitcher, and anywhere you like to listen to shows. Also be sure to check out BeyondTheMaskPodcast.com. Each episode is posted there with a corresponding blog post, and we timestamp important parts of the episode to help you quickly get to the content you're looking for. Also check out the special series section on the site. You can follow along and catch up on the CRNA History Series, episodes specifically about political conversations in the industry, or try the CRNA Personal Finance Series. It's all on BeyondTheMaskPodcast.com. And if you have a question for the show or want to be a guest, or even suggest a particular topic, fill out the contact form on the site or send an email directly to us at info@BeyondTheMaskPodcast.com. And lastly, let's take the conversation social. Check out our Beyond the Mask podcast Facebook page and Facebook group.